So subject of my talk is the contributions of cardiac cath in the decision-making after Starnes procedure. These are my disclosures. They're not particularly relevant to this presentation. But just going back to a little bit of background, as you know, the Da Silva cone procedure was first applied in 1993 in Brazil as the only true repair of Epstein's anomaly. And then as Dr. Da Silva presented in a video in the STS meeting, that is when the whole world started embracing the transformative therapy. And after the extensive experience in Brazil, Dr. Da Silva was recruited to Pittsburgh in 2016, along later on with his wife, Dr. Luciana da Fonseca da Silva. And that's when Dr. Morel created the Da Silva Center of Epstein's Anomaly. And so since then, the Da Silvas have performed about 150 cone procedures in the United States in patients that come with a variety of surgical histories, including prior stent procedures, prior Fontan procedures, and prior tricuspid valve replacement even. So how does that affect the cath lab, okay, for us? Well, we obviously, we used to, before Da Silva, we used to see about only 5 to 10 cases of Epstein's anomaly that came to a cath lab per year. And now in 2023, we had a record number of 40 among 800 cases that we do. And that has consistently been the case. About 30 to 40 cath patients with Epstein's anomaly come to the cath lab. And I look back and we have about 173 caths in these patients since 2013, mostly all happening in the last years when after the Da Silva arrived. But that doesn't mean that all these patients that we do surgery on come to the cath lab. Indeed, most of the procedures that we do not have prior cardiac catheterization in many of these patients, but some do. When we're talking about Starnes, all of them do. With preoperative cath, about a third of the procedures are preoperative, and 2/3 are postoperative. That means that patients that had prior surgeries, maybe elsewhere, maybe here, and they come back to a cath lab to determine the next steps. Most of the catheterizations we do in Epstein's anomaly are diagnostic, but about a third are interventional. And usually they are more in preparation for preventing complications of a Glenn procedure, such as coiling collaterals. That seems to be one of the most common interventions that we do, and rarely other interventions. So about 50% of the patients who go for cone procedure have a prior cardiac catheterization, and now all of the Starnes patients have a prior cardiac catheterization. So what I was going to try to do in the talk is go about some of the key findings on patients that we look for. What do we do with patients with Starnes that come to a cath lab? What is the key data you need to get? Some potential catheter interventions and whether or not that impacts decision-making. Just going back to remind us what patients we're talking about. We're talking about these kids who had severe neonatal Epstein's that were extremely sick, they underwent a Starnes, and now they're coming back to determine next step. They often have variable associations with pulmonary valve abnormalities, so often RV outflow tract obstruction, and may have pulmonary artery hypoplasia. The pulmonary arteries are compressed, and they, as you know, some of them have circular shunts, as was presented before. So these are these kids that come with a very, very bad history. They made it through. How did they make it? Because we decided to exclude the right ventricle. So through the Starnes procedure, the right ventricle was taken out of the equation. We sent the right ventricle out. And now we want it back, right? Now we're saying, okay, we want the right ventricle to take on a role. Is it ready? Can the right ventricle come back? So we get all these data, MRIs, cath. Can the right ventricle come back? And sometimes the right ventricle is very, very distressed, okay? And we don't know if he'll be able to come back. So what does cath, how can cath help us? As we see, after Starnes, there are two options. Some of these patients may be able to just go for a biventricular repair and get a cone procedure with a fenestrated ASD patch. But some of them may require ventricular rehabilitation, and that may be opening the RV outflow tract first if they had atresia or stenosis to try to get the ventricle to get some blood in, and then proceed to a biventricular repair later on, or stay as a 1.5 repair. So in the cath lab, one of the questions we have, is that right ventricle good enough? What is the size and function? Is it going to be able to generate a pressure? Is it going to be able to carry a cardiac output, a complete cardiac output, or half a cardiac output, or a third? And then, of course, we also have to make sure the patient is a candidate for a Glenn, because that's going to be on the table as a real possibility, especially if you try to do a biventricular and there's signs of RV failure, high right atrial pressure in the OR, you're going to do a Glenn. So you need to make sure the patient is a good Glenn candidate. So you have to do all the hemodynamic assessment for the single ventricle pathway, making sure the patient has low pulmonary vascular resistance, that the filling pressures are good, enter the pulmonary veins, get good, adequate calculation of cardiac index, PVR, QPQS, all that stuff. Assure you have good pulmonary artery anatomy, make sure there's nothing else that needs to be repaired at the time. And so these are these patients that we may find aortopulmonary collaterals that need to be closed to lower the bleeding in the operating room and minimize volume load on the left ventricle, and also potential veno-veno collaterals that could decompress the Glenn and make the child very sick with cyanosis in the early postoperative period. So then, another thing to take into consideration, these kids who had those huge hearts, the massive cardiomegaly can compress the pulmonary veins, and you can develop acquired pulmonary vein stenosis and atresia. And indeed, we have a patient that actually ended up losing the left lower pulmonary vein and has a stent in the left upper pulmonary vein, who's doing well clinically, but obviously has almost only one lung functioning. So that's something you have to look and intervene early to prevent losing that vein later on, which means in the cath lab, when these patients come, you're going to have to look and see, because it may be difficult to find otherwise. So you want to measure the pulmonary veins and assure that there's no stenosis, because if there is, it needs to be addressed very aggressively early. So obviously, we already heard that the anatomy of the tricuspid valve initially is critical. We referred to this paper before. We want to know what the RV outflow tract anatomy is, as that can impact the next steps, as was mentioned before. And then, what can we do in the cath lab? We measure RV hemodynamics, and we take pictures, right? Now, there are major limitations on our assessment of function in the cath lab, and it looks like also appears to be limited by MRI as well, because these ventricles have very limited preload. And they may also have a very abnormal afterload that will change after the surgery, because they may have atresia or obstruction in the outflow tract. So our assessment of that ventricle is very limited by those two factors: the limited preload by the Starnes and the outflow tract abnormalities that are common. So when we measure right ventricular pressure, and everybody says, what was the RV pressure? So what determines the pressure in the ventricle is a combination of factors: the preload, the afterload, the compliance, and the contractility. So when you're trying to understand ventricular dynamics, you have to look at ventricular pressure volume loops. And that end-systolic pressure-volume relationship, that pressure, the high pressure the ventricle can generate for that particular volume, that talks to you about the ability of that ventricle, the contractility of the ventricle, and also we'll talk about the diastolic function. But I'm thinking it would be great if we could get a ventricular pressure volume loop in one of these patients, because I think it would look probably something like this, right? Because the volume is really low, but if the contractility and the diastolic function are normal, you could argue that this patient is going to be able to make it a biventricular repair, that ventricle is healthy. How can we do that? That's a good question. So we do take pictures. We can enter and pressures. How can we do it? Typically through the fenestration of the Starnes, you can get into the ventricle. Now, if the patient had a Glenn before, you can do retrograde and get pictures and power injections, and you can get pressures retrograde through the Glenn. And you can look, when we look at the pressures that we measure in all our Starnes patients that came back for cone, there's a lot of variability. About a little less than half of them were really low pressure. Some had normal, some had high pressure in 3 patients for a variety of reasons. So significant variability in the pressures. So does the pressure matter? Here's an example of a patient that had a pulmonary valve atresia, and you can see that the pressure in the right ventricle was 42, And the patient looks like it has a pretty good contractility of that ventricle. And here's another, both who underwent successful comp procedures and did very well, who has a pressure for the right ventricle of 11, has a normal pulmonary valve, low pulmonary artery pressure, so there's no reason for that ventricle to have a higher pressure. So you can see that the variability in pressure doesn't really tell you too much whether the ventricle will succeed. And here, interestingly, we have an example of a patient on the left-hand side, I guess, that it has an RV pressure of 80 because it had a VSD, and you can see that in this patient, successfully was able to go. These two went for biventricular repairs directly, post Starnes, and here we have another one who has an RV pressure of 12. So RV pressure, I don't think matters, right? Doesn't matter. Okay, we knew that, but just I want to give you some examples. The next thing is function and size. We are very bad in the cath lab to assess function in terms of giving you a number because, for the left ventricle, you use a Simpson equation, but the right ventricle is very abnormal shape, so there's no mathematical model, equation that we can apply. So we can't really assess size. Sizes, they come in all sorts of sizes, and you can see them in the lateral projection and the AP projection. We do, obviously, biplane. But we don't really have a very good way of giving you an ejection fraction for the ventricle in the cath lab. One thing that catches our attention sometimes is it does appear that the RV end-diastolic volume of MRI seems to be less than when we do the power injection, almost like the power injection actually fills the ventricle. So does the power injection give more of an idea of what the volume potential this ventricle has? And it's interesting, if you could change those loading conditions, could you actually see the ability of the ventricle in any test fashion? And this is another patient. You have a low end-diastolic volume index by MRI, and the ventricle just appears better, but I cannot give you an end-diastolic volume index by cath because it's just, we don't have a good way of doing it. Really we are very limited on what we can assess in the cath lab because what we really want to know is what's the growth potential of the ventricle, what's the potential of becoming a two-ventricle circulation, how, if we intervene early, does that impact the ability to remodel? And then I am thinking if we could ever do ventricular pressure volume loops or figure out how we can expand the ventricle and get that volumes and contractility under MRI, that would be wonderful to understand dynamics and the potential of the ventricle. So in conclusion, I have to say that the right ventricle is resilient. You should not underestimate it. There are small ventricles that look like, no way, and actually they prove you wrong. We can also say that the right ventricular pressure does not determine the cone outcomes, but really helps us understand the hemodynamic state of the patient. We say that cath plays a role assuring candidacy for the Glenn for sure, helping prevent adverse events through interventions such as coiling collaterals and that kind of work. But truly it would be great to understand more how we can predict which patients are going to be able to just go directly for biventricular and no need a Glenn, so as that could really impact their management. We still have lots to learn. So thank you very much. This has been a great journey, and it's taken a lot of people to gather us together and learn some more about this fascinating disease. Thank you.
Thank you very much, Dr. Kreutzer. One question that came in the chat is there a role of, when doing the Starnes or like between the Starnes and the Glenn to try to open the RVOT in some of these patients?
Yeah, indeed, there have been patients that went for Starnes and had the pulmonary valve ligated at the time of the Starnes, or that had significant stenosis of atresia that have a hypertensive ventricle, where we have specifically done a Glenn and decompressed the right ventricle to help prepare the ventricle for the next step. So definitely there is a role for that. We, among all our caths in these patients, there was actually one patient that the valve was ballooned in the cath lab through a Glenn, so it's a balloon that comes retrograde into the ventricle. just to open up and help decompress the ventricle. So yeah, there's indeed a role for that in some patients, and I'm sure Dr. Da Silvas, they can also tell you which patients they would particularly be looking at that, because there are times you decompress the RV, leave the nasal gland, and then come back and do the cone. Yeah, wonderful
Excellent.
question. Thank you.
Thank you so much.